Today we'll be focusing on updates in acute stroke treatment. I have no disclosures. I want to briefly review the history of acute stroke treatment and then provide you with some recent updates. What we've seen in the last several decades is a shift in our approach in offering acute stroke treatment. We all know that age-old adage that time is brain, in which the pivotal thrombolysis and thrombectomy trials investigated a finite window for treatment based solely on the time of stroke onset or last known normal time. Following these studies, we looked at how we could expand that time window to offer treatment to more patients who could potentially benefit. We found from the ECAS-3 study and the Hermes Collaborative that a little more time is also brain. Most recently, we have seen several studies looking at patient selection based on advanced imaging, primarily with perfusion studies, but also with MRI, to identify patients based on the concept of penumbra or tissue rather than time alone. This has allowed us to consider treatment for patients up to 24 hours after stroke onset or last known normal time. However, we still know that time is of the essence when it comes to saving the brain, and our stroke teams should be mobilizing quickly to reperfuse the brain as soon as possible. The push to consider patients outside of a strict time window is based on our clinical experiences in the past that not all strokes behave the same. Many of us in our practice will see that patient who clearly had stroke onset within 1 to 2 hours before presentation, but already have well-established infarct on their initial head CT. Or on the other side of the spectrum, we have patients presenting after several hours of stroke symptoms, but have a pristine head CT with an aspect score of 10. We know that collaterals play a large role in whether these patients will be fast or slow progressors. So how has this paradigm shift influenced our approach to thrombolytic therapy? The Wakeup and Extend trials investigated the use of imaging studies, MRI for Wakeup, and perfusion studies using rapid software for Extend, to identify patients that could receive IV TPA when presenting more than 4.5 hours from last known normal time. Subsequent to these studies, the 2019 American Heart and Stroke Association guidelines have incorporated the use of acute MRI with positive DWI, but flare-negative lesions to select patients to get TPA. This was based off of that Wakeup trial, which included patients who